Good morning. Thank you for joining the San Joaquin County Healthcare Services Review Project Committee meeting. Today is Wednesday, July 17th, 2024, and it's 8:30 a.m. We will now call the meeting to order, and I mentioned it's 8:30 a.m. Ms. Rivas, can you do roll call, please?
Yes. Supervisor Canepa?
Here.
Supervisor Dink? Here. County Administrator Regallo? Ms. Hopkins?
Here.
Ms. Van Stein? County Counsel Kiernan?
Here.
Ms. Macedo?
She will be right back for the record. She left her phone upstairs.
Mr. Wolkamp?
Here.
Mr. Diedrich?
Here.
Mr. Castro?
Here.
Mr. Zinningetz?
Here.
Thank you, Ms. Rivas. Our first item this morning under action items is to approve the minutes from May 15th, 2024.
Move to approve. Second.
Anyone opposed? Okay. Ms. Rivas, can you note that Ms. Macedo was absent for this vote? Thank you very much.
Yes.
That concludes our action items. We're now moving on to information and discussion items. The first item is the co-applicant agreement and the memorandum of understanding between San Joaquin County and SJ Health. What I just wanted to touch upon this morning with our committee members is that the county intends on starting to work with our partners at SJ Health and our partners at San Joaquin General and other affected departments on both the co-applicant agreement and the memorandum of understanding amendments. Probably in late August, the Board of Supervisors will be receiving a briefing earlier in the month on August 13th. Once we receive direction from the board, we'll start the collaborative meetings with the group. Are there any questions from the team? This my update's very brief.
And Brandy, I just comment the SJ Health Board gave me authority to negotiate the MOU and I have to bring it back to them for final ratification.
Thank you.
I have a question. So then who's giving the input and where is it coming from and what's the intent?
So they'll happen in a couple different phases. Supervisor Canepa, so I'll focus first on the co-applicant agreement. As this team is aware, there has been a complaint filed by some physicians that the county has had investigated. So the Board of Supervisors will receive a briefing on that on August 13th. And during that, we will start to work with the board to get direction on how you would like to bring all parties back together to be focused on population health. Then we'll start with the liaison committee, which you, Supervisor Canepa and Supervisor Ding, who are on this committee, are also on the liaison committee. So we'll be having some meetings to discuss the co-applicant agreement with the liaison committee. And as you just heard, Mr. Diedrich has some direction from the SJ Health Board. So we'll be following your direction under the entire board's direction through the liaison committee. The MOU is a separate document and it outlines how the clinics receive services from other county departments. So the hospital, the auditor controller's office, human resources for insurance purposes and different things. And we're going to work on making sure that that's refreshed and updated. That has been in place for several years and it needs a refresh.
Okay, perfect.
And Brandy, I just add, I think getting the set of recommendations, that is, it's been pending for a while, but that's a reason why we've not formally stood up the liaison committee. But I think post getting information from that report will inform a lot of where we need to go potentially with the co-applicant agreement and the MOU. But we would need to formally stand up the liaison committee at that point in time, which is a Brown Act and formalized.
And just for the record, because I want to make sure, that was a request of us, of the hospital, starting in September of 2022, that the MOU be renegotiated.
Thank you, Mr. Castro. Any other questions on this item?
Brandy, I have a question. The current MOU terminates at June 30, 2025. Is the intent that the new version of the MOU go in effect as of July 1st, 2025?
I think we'll have those collaborative discussions and determine the effective date or the recommended effective date at that time. So
Very good.
that may
Thank
be
you.
a different date. Okay, our next presentation will be from Mr. Zuniga and Mr. Diedrich on the SJ Health. This is the historical financials. So as this committee has heard some discussions about how SJ Health or the clinics and the hospital when they split, what the financials look like. We've been working as a team to collaborate and have that discussion, and Greg and Chris will provide that update. And then we're going to discuss the quality incentive pool, commonly known as the QUIP. Just for the committee notes, typically we have regular financials, monthly financials at this meeting. And since we're moving to quarterly, we're going to move those to quarterly financials. So you'll receive financial updates from both the hospital and the clinics in October. Today, we're just focusing on the historical financials. So I'll turn it over to Mr. Zuniga and Mr. Diederich. Thank you.
Thank you, Brandy. Appreciate it. Good morning, committee. It's a pleasure to be in person amongst you today. So before we get into the meat of the presentation, I just want to set some context. I began serving the County of San Joaquin as CFO of the FQHC in January of 2020. Coinciding with the beginning of the public health emergency. At that time, the perception of the county in general, particularly county administration headed by Monica Nino at the time, was that the FQHC was an underperforming piece of the county from a financial standpoint. So in March of 2022, the Board of Supervisors approved a closing of 2 of our clinics, the Manteca and Hazelton Clinic, and also we had to reduce our workforce by 40%. And we did a Bielenson hearing and manufactured the workforce reduction at that time. Fast forward to June and July of 2020. The clinics which were operating on interim rates and being reimbursed on interim rates, the 5 initial clinics received their PPS rates in June of 2020, and then in July, we received word from David Showalter of Eide Bailey, the county's independent auditor, of a recommendation to split the FQHC from the hospital and parse out a balance sheet from the hospital balance sheet. Okay. So in October of 2020, for purposes of creating standalone GAAP statements, which would be a balance sheet, income statement, and statement of cash flows for the FQHC, Toyon and Associates, a consultant that is still a vendor of the hospitals, and Eide Bailey, the independent auditor of the county at the time, were contracted. Toyon's assignment was to identify the supplemental funding that was associated with the FQHC, that is earned by the FQHC on behalf of the county. And the relevant period for this examination was the beginning of the FQHC, July 1st, 2024, through June 30, 2020, roughly 6 fiscal years. Toyon examined all supplemental funding that the FQHC sort of earns on behalf of the county and surmised that $112 million as of June 30, 2020 were revenues identified and associated with the FQHC per their analysis. Taking that analysis, and I use the term supplemental funding because this analysis went beyond QIP. But the bulk of these monies and the bulk of this analysis was the prime and QIP programs, which are now all rolled into the one QIP, or Quality Incentive Pool Program, which we'll be discussing later in the presentation. And that was about 108 of this 112 million. So taking that analysis and also the hospital trial balance, Eide Bailey parsed out GAAP financials as of June 30, 2020. Eide Bailey, in November of 2020, produced financials which outlined assets of 46 million, liabilities of 15 million, net assets of 31 million, and a fiscal year 20 P&L revenues of 48 million, expenses 31 million, and net income of 17 million. These reports, both the Toyon and the Eide Bailey financials, were sent to the hospital upon their construction. And then as we progressed with sort of the beginnings of the MOU and other separation matters, and I guess getting through the holidays and the beginning of the next year, calendar year that is, in March of 2021, we started to hear from the hospital that they were displeased with the results of the equity of the Eide Bailey financials. And so David Culberson and Chris Roberts produced alternatives to the produced financials that this county had sort of bought and paid for. Yes, sir.
So net assets at that point, can you tell me what that included? Because, right, there's no property under, right? The clinics don't have,
No, it was retained earnings,
okay.
yes. So effectively, the calculated revenues were greater than expenses over that 6-year period. Well, the balance sheet is a cumulative report since the beginning of time from an accounting standpoint. So that's why that would be the 2020 balance sheet at net assets of 31 million. However, the P&L represented just below is a 1-year period. Dr. Fadu and I received communication from the hospital of 3 alternatives to the Eide Bailey financials. And effectively, the only acceptable, as we were told, alternative was one where the FQHC would split from the hospital with 0 net assets and 0 net equity. When I brought this up with the county administrator at the time, Jay Wilverdane now, he expressed that this was a decision that was the result of a conversation between David Showalter, the Eide Bailey partner, and David Culberson, the CEO of the hospital. No other detail was really shared beyond that. So we took it. We were made to take it. And 31 million was effectively erased from the Eide Bailey balance sheet.
Quick question, Chris. There were 3 proposals for the conversion of the clinics outside the hospital. Am I correct in that we didn't choose any of those 3? We picked a 4th. There were the 3 proposals that I saw weren't the ones that were chosen. So we picked a 4th that was outside the recommendations of the consultants, correct?
The consultants only produced the original financials, okay? The hospital had a spreadsheet that had 4 columns. The first column, option 1, was the original Eide Bailey produced financials. The second option was an option that was just not feasible for the FQ, in that the FQ would end up owing the hospital for 6 years of business and we were being birthed, essentially, for lack of a better term, with no cash. I believe that this option was select, and the third option was similar, but to a lesser degree, where the FQ would end up paying the hospital. This option would circumvent having to restate audited financials because the hospital net earnings would remain unchanged. And I think that was the, apart from, having to transfer, avoiding having to transfer monies from the hospital to the FQ to the tune of about 28 million or 38 million. The 0 equity response from the hospital reduced that number to about 8.1, and that's what ended up occurring. When we split from the hospital and had our financials audited, the hospital confirmed that the zero equity response created this reality where at July 1st or June 30, 2020, the FQ effectively was a break-even operation since its inception.
Quick question, so back in that day, that's when the QIP ratios were decided?
No, so simultaneously with this process, like just getting us financial statements, simultaneously, we began the process of, under the direction of Deputy County Counsel, we began the process of drafting a memorandum of understanding wherein the FQHC purchases labor and various other support departments, insurance, everything Brandy just said, but also the FQHC serves as a vendor to the hospital in this case for things such as earning QIP and the price for these things bought and sold. The MOU did not get fully executed until October 22nd, 2021. Some 7 months after these financials were created.
Okay, and then, so then is this the start of the 80-20 split? Because it's 5 years, right? So when does that start? Did that start?
The
At the
MOU
beginning,
was
or what's the-
retroactive, even though it was executed in 2021, October 2021. It was retroactive to July 1st, 2020.
Okay, thank you.
Yes. So I was against this at the time, sort of still against it, but it's what occurred, and we moved on from there. However, I did, for the record, I did inform our board via our monthly financial narrative, and every month, beginning April 2021, there was a note saying that the hospital submitted adjusting journal entries to parse out the FQ and effectively make us a break-even operation since inception. Okay, so this is an analysis of our expenses and the growth of our expenses. It's been brought up that there's been tremendous growth in spend. And what we've done here, if you recall from the previous slide, our expenses as of the split were 31 million. I'm now representing a slide that shows fiscal year 20 expenses at 21 million. What's the difference between the two? As part of that split, Bailey used a modified Medicare cost report to impute history to date overhead charged to the FQHC. So there would be, to get us from the 21 million represented here to the 31 million represented on the previous slide, there's 10 million of overhead for HR, IT, what have you, from the hospital. However, Abe Nunez, the former CFO of the hospital, gave us a similarly constructed examination. And once he made the clarification that his examination was excluding the MOU expenses, we were perfectly aligned. He was not saying anything that I would not say, and I'm saying it here. We agree that our expenses have grown. There are several functions, both patient-facing and support, that have had to be purchased outside the county system. I remember Supervisor Ding, a couple of Board of Supervisor meetings ago, you're on the dais saying, just tell me what you need. Tell me what you need, speaking to one of our department heads. This is that situation. You know, we do our best, and county administration and HR has been wonderful, especially in the recent years, in particular with our fiscal '25 budget, to sort of change the norm and get us more positions. But frankly, the talent hasn't necessarily been here in our talent pool and in our applicants. So that has required us to contract for our virtual care, for example, our medical providers, nursing leadership, social workers, clinical staff, information technology, fiscal leadership and accounting, project and grant management, marketing. We just went through a HRSA operational site visit. It's a very involved process that FQHCs go through every 3 years. We had to hire experts to help us navigate that process with our auditors, our HRSA auditors. That's a normal purchase for FQHCs. Lots of FQs do that.
Chris, what's the budget for fiscal year '25?
The budget for fiscal year '25. Our approved budget that was approved by the Board of Supervisors as well as the FQHC Board, the expenses there are $58.5 million. So,
So the reason I asked the question, and the reason, look, we're trying very hard to move this in the right direction. You all know that I don't feel that the MOU was the right call from a hospital perspective. Doesn't mean we don't need to work together. It doesn't mean that we don't need to do anything else. But I bring this up importantly because I see the future from a healthcare perspective that is very challenged, especially if we see a different administration that's going to be less likely to approve a lot of the federal public funds that we get now, which are growing rapidly. So we have to, you kind of have to plan for a rainy day. And my issue has always been that, and right or wrong, my issue has always been that the clinics, we took the wrong approach from the clinic perspective, and we've in a sense forced additional expense because a lot of those services, and we can talk about, we're bringing them back now, like medical staff, which should never had been, credentialing should have always been under a single entity, all of those things. The truth of the matter from a revenue perspective, from the bills produced from the FQ, and remember, I keep saying this, both Golden Valley and CMC receive no public funds. I'm not saying that the clinic shouldn't. I'm just reminding everyone that the other two competing FQs in town operate without them. And my biggest concern is, from a cost perspective, whether it was 21 or 35, to be 3 years later at 58 with no additional really, the revenue volume stays pretty consistent, although it's been up recently, but there's no possibility without taking from those QIP funds, which are critical to the hospital as well. And the reason we should all be rowing in the same direction with healthcare and population healthcare, those expenses have been my biggest issue from the very, very beginning. And I want to make sure that we don't, in going through this process and how it is allocated, I want to make the comparison that we should all be asking is if Golden Valley can do it and if CMC can do it, why can't we get closer to doing it? Thank you.
So in an FQHC, we are
Mr. Zuniga?
Yes.
I'm going to pause just for a second because we have staff here today and one of the staff members has a comment, if that's okay for your presentation?
That's great.
Okay.
Good morning. Good morning. So once, sorry, I do have a question, Mr. Castro. You said that from a healthcare perspective, I assume you're speaking from a hospital perspective, from a federally qualified health center perspective.
No, I'm speaking from a population health perspective, which
Okay,
is what
well, I
we-
just want to make sure that the committee understands, from an FQHC perspective, the funding has been here and it will always be here. So that's not going to change. And the future is in population health in FQHCs. So, you know, I just want to make sure it's clear from where I sit. I've been doing this 30 years around the country. It's not going to change. The money is here. The other thing is that Golden Valley and CMC get huge federal grants to support them, which we don't get at this time.
I'm sorry for my ignorance here. Can you identify yourself so I know what perspective you're talking from?
My apologies. My name is Ruben Pettiford. I'm the interim COO at SJ Health, and today is my 6-month anniversary.
Congratulations.
And what Ruben's referring to is, we are a lookalike, whereas Golden Valley and CMC and the vast majority of federal qualified health centers are what are called 330 grantees. So they get baseline funding from the federal government. They get some tort coverage, but also being a 330 grantee, the vast majority of HRSA grants are only available to 330 grantees for specialized populations, homeless, migrant farming, and congregate housing. But they have a lot of sustainable ongoing grants in that regard.
What percentage of their budgets are this money? I mean, that's pretty relevant in what we're talking about. If we don't know what our competitors' base that they get that we don't get, would be nice to know. I mean, it's great to talk about it, but until I actualize it and see it, then that makes zero sense to me.
Supervisor Canapai can add that for our next meeting,
Okay,
so we
thank
can
you.
have a little
So
presentation.
we can see that what they start off with and, you know what I mean, what dollar amount
familiar
or
with-
percentage of dollar amount is in their revenue would be,
Ms. Rivas, and I'll make a note, and we will work with the,
okay.
both
Because talking
parties.
about, I mean, that's great. Do they get
Very good
500,000? Do they get 10 million? Do they get
Yeah.
20 million? So it's kind of moot, so.
We will work
Okay.
for an October presentation, because that might take a little bit of time to collaborate with our partners.
Okay, that's perfect. I mean, just to kind of get a rough percentage, you know what I mean? So so we can compare apples to apples and see, I mean, if we're gonna be looking at the MOU and things like that, then we need to know, you know, because you're not pleased with it, that they took that money away. What was that money? They're not pleased that they didn't get the 20% over the 5 years. So it goes both ways. So, I mean, it'd be nice to be able to clarify that.
Will
And I
do.
would say the 990s for both those entities through 2023 are available, and CMC is not turning a profit.
Yes, to
Whoa,
piggyback.
But I'm just saying the start
Can you just say
money.
that again?
The 990s, which are essentially the tax filings for a nonprofit, are available through calendar 2023. So looking at that for calendar 2023 and calendar 2022, CMC's had net losses in the $1.8 to $2.2 million range each year.
So for a good comparison, do the FQ without the MOU and see what that deficit is, right? Because it's not 1.8 or 2.4 million. It's significant.
So CMC and Golden Valley, as Ruben mentioned, are Section 330 grant recipients. We can do sort of a deeper dive into what financial information is available for those FQHCs. I do have the 990 in front of me, and it lists contributions and grants of 28 million and 27 million respectively for fiscal year 2022 and 2023. Greg is right. In 2022, their audited losses of 2.7 million, audited losses in 2023 are 1.9, and their cash balances are not great either. But we can defer to another meeting on those particulars.
I think it would be helpful for the two Board of Supervisors members to actually see a presentation, and explain what the difference is between an FQ lookalike and what CMC and Golden Valley are, because we didn't agendize that for today.
Okay, no, just for, future, and I
Yeah,
mean,
so we'll
because
bring
they
back
don't,
a full
the other side of it, they
presentation
don't
for you.
get quip. So I mean,
Yes.
there's give and take that I'm learning
Yeah.
and knowledge.
So I
is-
want to veer too far off the
Okay,
agenda,
sure.
although county council hasn't smacked me yet, but
All right.
I feel we can bring you a presentation that's
bathroom
more,
Yeah, go get your phone again.
that
No.
has an actual presentation for our committee to see. And it would be a good education for all of us. Thank you.
So I would submit that if we are taking a look at the FQ financials without supplemental funds, then we should also take a look at the hospital financials without supplemental funds and see what those expenses.
You know, there's no question, Chris, we don't exist without them on 9 cents on the dollar. It's really important that we get them. You know, again, I'm the lightning rod here, and I don't mean to be. When I came here, I was shocked. I was shocked by the MOU. I was shocked by the lack, and this has no reflection on the people sitting in this room. This has absolutely no reflection. It wasn't their leadership. It was done in a way that was, number one, quickly get done before the MSA is executed. This went to the board the month before the MSA was executed. So there was no collaboration between the medical staff and key members of it. And you could, you know, Dr. Dulio could verify with me here, if we're making decisions about the change in the entity, the medical staff needs to be involved. And the only conversations in that were between David Culberson, Jay Wilverdine, and Dr. Fadu. Nothing from the medical staff. One day, we show up, all of a sudden Fadu is the CEO of the clinics, Fadu is the CMO of the clinics, the Fadu is the blah, 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 blah. And they go out with the MOU, and I look at it and I say, okay, now I've learned a couple of things here. Our cost structure under the hospital was $21 million, and there is overhead cost, blah, blah, blah. That's true. That value could be disputed. But it certainly isn't $58 million. And why I call that out, it's not because they're misusing the dollars, it's because taking those services that are duplicative, all of them, is senseless, right? There's no reason for us as a public health entity to have an HR section with the clinics and a different HR section at the hospital. There's no reason for them to have their own credentialing when we already do it at the hospital. And my complaint goes from both sides. If we were going to, in a sense, parse that out, then from the hospital side, there should have been a reduction, right? If we're no longer covering the clinic physicians for the medical staff coordination, and the way that works is we get rid of the employee that was responsible for that, and that employee goes to the clinics. But that's not what the organizations did. They kept the whole structure of the hospital the same. They didn't change a thing. So they gave them less responsibility for no money, and for no decrease in money. And all of those jobs done on the external side are the reason that number is continually rising for all of us. But it is unnecessary in the fact that without doing it with a here to there doesn't make sense. And we are tied to the hip, right? You know, we need the public funds money. We have a disagreement with how that should be, but let's stop that right now. Let's just say, here's the money for the health system. How do we much more prudently do it? And the reason I'm screaming on the top of the hill is because all of those duplicative services don't need to be. And it's not, understand that the population that we serve is the worst paying population in the world, right? Straight Medi-Cal is 9 cents on the dollar. Medi-Cal managed care is even less. So in this ridiculous the way that we have set up healthcare, are you doing that to me, Greg? The ridiculous way that we are setting up healthcare makes these problems significant. It is really important that we figure out a way, and we've gotten better, but we sit down and we look at where the expenses are, how do we reduce them, because at that, you know, the hospital has, over the 2 years I've been there, we're not reporting them, but we've been able to eke out profitability on both years. We're very proud of that. Prior to us coming, without the pension pickup, fiscal year 2021 would have been like a $30 million loss from a hospital perspective. So we're very proud, but a lot of that has come from monies that we've picked up from
things that weren't done in the past. In other words, we got some pickups for past years by going back and rebilling and doing all those things. Those things go away for us. So we need to operate much more cost effectively, because what you all don't want is the hospital or the clinics or the health system as a whole to be a burden on county tax dollars. And I just don't think that, I don't think that we're looking at this from the wrong perspective, because we're so, you did this, I did this, and I'll take full responsibility. I'm not a shy person. I'm very passionate about what I do. I'm very passionate about making this work right. But that's the bulk of the argument. How do we change the expense structure? How do we, we go back to the same question over and over again. Why was this done this way? When the recommendations, the 3 recommendations that were set up, and you disagree with them as well, Chris, none of those were followed. So it feels like there was it doesn't feel like it was done for the right reasons. And because it was done so, in a sense, under the covers from everybody's perspective, we're very much challenged. And some of the downhill effect of us not being tied to the hip, moving forward in the same direction, is scenarios like, we have a family medicine residency. We have 8 residents that graduate from our residency every single year. We should be able to keep those residents. We should be able to keep a couple of them. We pay well. We pay better than Golden Valley. I don't know. I believe we pay better than CMC. But it's, if we don't admit, as a whole hospital and FQs, that we have opportunities that we're missing, then we'll continue to miss those opportunities.
So before we get back to the presentation, thank you for those comments. I think that's really what we're trying to start to focus on under our new leadership. We have the opportunity with these 2 board members and our county administrator. We've been working closely with both the hospital, the clinics. We work with healthcare services very closely to, after today, since we spent a lot of time in this committee talking about history, move forward and really take all of the brain power in this room to create a system that serves population health and serves it in a meaningful way. And I think CEO Castro, you've been talking about that, and we're really hoping that that's where we start today. We go ahead and talk about the history, close that loop, and move forward under the board's direction.
I mean,
Green light. You have a red light. Thank
I've
you.
learned about this. So the new microphones are politically sensitive in the state. So you gotta stay back from it. They don't like you to be in their space. Otherwise, they cut out. I guess what I'm hearing from both of you, and thank you for what you just said, because at the end of the day, how do the clients get served? How do we take care of people? But I'm hearing both of you kind of say, before we move forward, we kind of need to turn the clock back. Why did we do what we do? Maybe it wasn't done right. And I keep hearing both of you in disagreement about the change for whatever reason under a past administration before Paul and I were here, why it happened. And we need to address that. I think that's what we're doing here.
That is the, hopefully the intent and the conclusion of today's presentation. And then we can move forward, Supervisor Ding, and really focus on population health with our entire healthcare system. And when we meet with the board next month, you'll hear that message from the CAO and myself as well.
My name is John Dealey. I'm the Chief Medical Officer for San Joaquin Health Centers. If okay, I'd like to make some clarifying statements, whether it be historical QIP, other institutions, because I know we were talking about Golden Valley and CMC. I'm in a lucky situation where I partake in California Healthcare Foundation Leadership Fellowship, 2-year fellowship, with 30 established leaders within FQs and hospitals across the state for a 2-year fellowship. A lot of my colleagues that are a part of this are either chief quality officers or chief medical officers at other FQHCs that I get to meet with often, monthly, if not more if I need to call them, where we talk about best practices, what our struggles are, et cetera. When we talk about quality incentive program pool and revenue splits. My colleagues at these other FQs, the clinics get the lion's share of those dollars. And when I say lion's share, I mean 70%. This is factual, right? So the initial dollars will go into the system, but it matriculates to the clinic for what that's worth. The other piece with Pop Health, I mean, yeah, we are the ones spearheading Pop Health within the county. You know, very aggressive with Pop Health. Also very aggressive with the residency. Under previous leadership, there was kind of a negative connotation between SJGH, as you've seen with the conflict that we've had, and the clinics, which was you know, kind of a roadblock, right? And those are things that we are improving. We are and working well with the residency. I have a great relationship with Dr. Jaffrey, but it was deeper, as just like this was. That matriculated to all of the employees, and that's what we're trying to get away from.
You know, and again, it's irrelevant because what we're really trying to do is move forward. I dispute that fact. That's not what we heard from a QUIP perspective. That came from Tuan, that came from Almeida, that came from Costa Cana, but it's irrelevant. We have a bucket of money that we need to move forward with. We need to move forward with it prudently, and I want to continue to say that from a cost perspective, by bringing us together, we can do so much better than what we're doing, and that's what we need to do, because Dr. Dulio is right. We're not losing residents because of money. We're losing residents from both perspectives because of it's not a place for whatever reason after they've experienced it that they want to come, because we all need to do a better job to, you know, to move forward.
I'll give an example, right? In all fairness, the very first time I met Rick, heard him speak, was at a family medicine residency meeting where talked for about 10, 15 minutes about how upset he is with the FQHC and the MOU. The audience was residents. So when your boss, CEO of the hospital, is telling you how terrible the clinic is, that builds not a great relationship.
My
So,
point,
team, we're getting beyond what was on the agenda. And just as a reminder, because I have to remind our team sometimes, I appreciate everybody's professionalism, so if we can stay on track, stay professional. But I think we'll go ahead and turn it back over to Mr. Zuniga for the agenda. Thank you.
Thank you, Brandy. So the punchline is here that our expenses did grow, have grown, are growing, but they are controlled. They are conscious, and they are monitored. The next slide shows our County Board of Soups and FQHC board-approved expenses for fiscal year 22, 23, and projected for, well, the approved is up there for 24, but the actual is projected for 24. In no fiscal year have we gone above the approved amount. We have controlled our spending. We know the direction that it's going, and indeed, we have a Board of Supervisor approved budget for fiscal 25 at 58.5, but we added 41 new positions. This organization has its control on spending, but contrary to normal businesses, and this is something that is an FQHC nuance. An FQHC controls costs, but it is not necessarily cost averse. Why is that? Unlike most businesses, we can effectively, and it takes time and it's not instantaneous, but it is something that distinguishes itself as a business. We can manufacture a raise. Our reimbursement rates are based on our expenses. Effectively meaning the more we spend, the more we can make in the state of California. And we know that. Again, I just want this to sink in. SJ Health has not spent more than the approved amount in any fiscal year, and it will not do so in fiscal '25 either. Does that make sense to everyone?
Again, the fiscal '25 budget, go back to the slide, go back a slide, Chris, please. Your current budget sits at 47 million, that's what you're projecting to spend this year. Next year's budget is at 57 million.
And I just said that we added 41 positions approved by the county.
Which we have to budget for the full year. We're not going to be anywhere near 58 million in expenditures.
The expectation is also that with the
Why would you budget?
41 positions, because I get you confused with the district attorney. but
Very similar.
Is that, that will also start to decrease some of the other contracted services,
Exactly
just as
right.
we do with every department when this happens. So again, you'll be able to focus on community population health through the county system, and we appreciate that.
That's exactly right. So outside of our MOU revenues, the largest component of which is the QIP supplemental funding, we have increased revenues since June 30, 2020. We added a 340B pharmacy program, which did not exist here in this county. It's over $1 million a month. Well over $1 million a month. Well over $200,000 a month. $3 million a year.
So the hospital has a 340B program? Wasn't-
You're a
yeah,
purchaser.
Yeah, and
at 340B.
wasn't it in place with the clinics?
No.
Okay.
So we have always purchased at 340B pricing. That's not what this is. For FQHCs, we are allowed to have internal pharmacies or contract with external network pharmacies like Walgreens, Rite Aid, Safeway, Walmart. And our patients fill their prescriptions there. And we keep the difference between the purchase price of the drug and the sale price. We pay the network pharmacy an administrative and dispensing fee. And I got that started in 2020. Our visit volumes have increased. They were larger in '23 than they are in '24, but it still means $2 million to $3 million in annual revenues each year. Grant revenues have fluctuated between 3 and 5 million additional since fiscal year '20. And indeed, there's more to come. We are in the process of converting 4 of our clinics to intermittent FQHC sites. This process could mean an additional 5 to 6 million in annual revenues here at the county without doing much different at all. Same business, more money. Good question, Supervisor Canepa. So right now, our French Camp clinics and our California Street or Stockton clinics are all sort of freestanding FQHC clinics. And each one of those 6 clinics has their own PPS rate. And I apologize again for the acronyms, but it's Prospective Payment System. And that's the basis for an FQHC's reimbursement. However, in the state of California, we have the ability to convert freestanding clinics to what are called intermittent clinics. And there are certain limitations. The biggest of which is we are limited in terms of operating hours to 40 hours per week for an intermittent clinic in the state of California. But if you have an intermittent clinic, it no longer bills at the PPS rate as a freestanding clinic. It bills at the chosen, the FQHC chosen parent site PPS rate. So we have a particularly good PPS rate at our Healthy Beginnings French Camp Clinic. That clinic will be the parent site for our primary care clinic and for our FMC, Family Medicine Clinic. All right, the PMC PPS rate is somewhere around $160. FMC is just under $200 a visit. The HBF, or Healthy Beginnings French Camp Clinic, has a PPS rate of $312. So the bulk of our business, the bulk of our visits are Medi-Cal based. They're either managed Medi-Cal or straight traditional Medi-Cal. Ultimately, all of those visits, which equate to 85% of our visits monthly, are subject to that PPS rate. And now, because of these conversions, they're at that HBF 312 rate. That's the intermittent conversion. That didn't exist by the 160 to 312, yeah, yeah. And by the way, and I don't want to get too far in the weeds, I know we have an agenda. This ability for public health systems to create intermittent clinics, there wasn't a legal avenue to do this. The state was sort of doing this off the cuff or just flat out denying because the regs didn't say that we could. We got excluded. All public health systems in the state of California got excluded because the language said 4 licensed clinics. Well, FQHCs in public spaces are exempt from licensure. And what that accidentally did was excluded us from being able to have a mobile clinic and have it be reimbursable under PPS, and exclude us from the ability of using intermittent clinics and having that be reimbursable under PPS. We've changed that. Not we, the collective community of public health systems, we, the County of San Joaquin. We got DHCS to approve a process for converting or establishing intermittent clinics approved over email, so that's our documentation for that. But moreover, we began discussions with Senator Eggman's office, and Senator Eggman's office issued California State Bill 819, which is soon to pass within the next 12 months, giving all public health systems a direct path to not only intermittent clinics, but also mobile clinics that are reimbursable. So I mentioned that FQHCs are not cost averse. We're not. Our business has the ability to change our reimbursement rate. So that 312 that I just quoted can be more if certain conditions are met and if certain processes are followed. It takes a long time here in the public space to do that. It's not quick. It's like 3 to 5 year process. In traditional FQHCs in California, it's not that long. It's like 18 months. But that's what we have to live with here. But it is the case that our reimbursement does not remain stagnant. It can grow. So I wanted to inform our committee and our Board of Supervisors of these realities. One thing I would also say is that my board hears from me every single month, and Brandy is there every single month. My board hears the FQHC is not profitable without QIP. It's not a rosy statement saying we're a well-oiled machine and we're doing everything perfectly. And no, there are things we certainly can improve. And the QIP monies makes us a profitable organization to the tune of 26% in 2011, 20% in 22, 14.3% in 23. And it's going to be significant in 24 also. But the point is, we are very transparent with our board and the message that they receive. But let's talk about the Quality Incentive Pool program. The Quality Incentive Pool program is a managed care directed payment program that challenges public health care systems to improve equity and quality For Medi-Cal managed care enrollees via ambitious pay-for-performance targets. Those are not my words, those are the words of the California Healthcare Safety Net Institute, which is an advocacy group that partners with the California Association of Public Healthcare Systems and Hospitals. And they advocate with the state on our behalf. The font is kind of small on this side, so bear with me, there's a lot of detail here. Program year 6, otherwise known as calendar year 2023, began January 1st, 2023. The reality of the Quality Incentive Pool Program is that there are programmatic changes every single year, and it gets harder and harder to earn these dollars every single year by construction of the program, by design. The funding flow flows from the state to the health plans, and from the health plans to the public health and UC systems. You've heard me present on this before. There are 12 counties that are participating and 5 UC systems. The largest component, the lion's share, around 24% of the available funds are going to Los Angeles County. There are 9 reporting domains: behavioral health, care coordination, care of acute and chronic conditions, experience of care, improving health equity, maternal and perinatal health, overuse and appropriateness, patient safety, and primary care access and preventative care. In terms of the reporting requirements, there are 9 measures designated as bold goals. All of those are found in the primary care setting or SJ Health. There are 31 elective measures from a menu of 48. 37 of those are in the primary care space, and 11 are in the inpatient space. So primary care does carry the disproportionate share of a burden for performance. And the reported 40 measures that any health system or UC system decides to report on are locked in only at the time of reporting and can be modified at any point until their submission. I think there's been some confusion on that point.
Except the bold gold we have to report on every year.
Right, so the 9 bold goals are mandatory reporting. And we have no option there. So DHCA makes QIP distributions via the health plans 15 months after the calendar year end. For example, program year 5, otherwise known as calendar year 2022, was paid out just this past March 2024. Takes a while to get your cash. And I explained the process a few meetings ago, but so for example, for program year 6, we turned in our results on June 14th, Friday, June 14th at noon on the metric side of things. But that does not determine the slice of pie that we get. The slice of pie is based on the number of patients that have been seen in the managed care space. And we discussed that a few presentations ago. That will be reported to the state by all 17 participants in September. And then in November, we will get a grid, a spreadsheet that will tell us which participant got which portion. And we will know. Right now, the program year 5 portion was about 3.5% of the pool for San Joaquin. It may have gone up, it may have gone down. So we need to understand these particulars because our reported performance for the year turns out to be 86.68%. We are making improvements on these metrics. On the primary care side, or SJL side, we reported 33 measures. The 9 priority, which we just spoke about, those are mandatory reporting, and then 24 elective. Out of a possible 33 achievement value points, the primary care space earned 31.67 of those achievement value points, or 96%. In the inpatient side, we had 7 elective measures, and we had an achievement value of 3 points. or 43% of the possible achievement value. So the total achievement value points of 34.67 equated to that 86.68% of dollars earned for PY6. And the rollover amount, remember, this is a special year, right? We're getting to earn the money that was unearned for PY5 in PY6. So let's look at an estimation of what this could mean in dollars. And I say estimation, find the word estimation 5 times on this side because, again, we have not seen the unduplicated patient count for all of the participants, meaning we don't know how big of the pie belongs to, how much of the pie belongs to San Joaquin. The other piece, and the state is being very bashful about this, the rollover pieces. We just assume that that unearned rollover from PY5 is going into the pot and just being tacked on. That's that $11.1 million figure you see here. But the state has been very quiet on this. So this is an estimation under the assumption that it just gets tacked on. There are other ways to treat these monies, but the state has not issued specific guidance on that particular. So again, the word estimation is featured 5 times on this slide. But assuming it's one pot, and assuming the metrics qualify us for it, we had $63.5 million that we could have earned as a county together. But our performance dictated that we have an estimated earned of $55.1 million. We have unearned net revenues of $8.5 million. So in terms of earning the funds themselves, by virtue of the achievement value scores or points, 91% of the earned funds came from the primary care space or SJ Health. 9% of the earned funds came from the inpatient space or the hospital.
Okay, so this is where I need to speak up. The QIP funds basically were designed to do the right thing. It was to push the organizations to make sure that quality care was delivered in the space that it should have been, and for example, not in our emergency rooms. So the metrics are, you can't, and the whole rationale, and again, I think what would be really good for this board, because we certainly dispute where the QIP dollars, bring somebody in. Bring somebody from the California Association of Public Hospitals in and have them discuss the QIP program with the board so we can all better understand it. That would be my recommendation. But if you look at, for example, an inpatient metric, and let's say the inpatient metric is, breastfeeding, right? That is quote unquote an inpatient metric. But understand the patient starts in the outpatient system, and the patient sees their provider month after month. And as a coordinated effort, and the reason we need to bring this together is that's where that education for breastfeeding would start, right? That's where it would start. So at the end of the day, what they've done here is they've broken out inpatient and outpatient metrics, and they make the assumption that the earn is based on the success of those metrics. That's a false narrative. The money, whether it be the hospital or the clinics, is earned in achieving those metrics. And so for all of them, what we haven't done yet is we haven't sit together with a hospital quality team and the SJ Health quality team, and we're doing it, and put a spreadsheet together and say, these are all the metrics that are possible. So when we get to that June date, we can say, these are the 40 that we're gonna report, so we maximize that money. But what, this is apples to oranges. It's not fair to say because 80% of the metrics are performed by the FQ, therefore we should get 80% of the QIP. It's just not, and again, don't believe me, bring in somebody who's an expert so we don't continue to have this battle and understand again, the challenge is on the opportunities to save on the expense side. That's where the opportunities that we're missing completely are. And if we don't recognize that, it's going to be a challenge for the health system down the road.
I have one question. So that one chart that you read earlier, I didn't see in the things of the percentages as it increases on the quit, whatever you, it was 11% or did I you
Is this-
said,
this
you
is-
spoke it, it's not on here. though.
I
You
see.
spoke
Yes.
about what percentage. Well, if that percentage gets down to zero, then if you're relying on that quit money to keep your budget balanced, you're gonna have problems. Because as that number, regardless of whether you say what you're saying or not, it seems like a trend. And so that would be the most alarming part, is that if you are up higher with your quit money now and it's as it's shrinking, then as you get that to zero, what backfills?
Okay, so I believe Dr. Julio has some comments to address what was
Okay.
just said, but I will address your comments,
Okay.
Supervisor
Because that's
Canepa.
just a concern. I mean, if
I
that number
understand.
keeps shrinking, if there comes a point in time, or if that doesn't get fixed, or if we don't start sharing it or figuring out how we work together to maximize it in whatever category you're submitting, I think is huge, so.
Of course.
So there are no plans for the state to reduce these pools. In fact, the plans are to increase, and they have been increasing up to this point, about 3.42% each year. And the increases will actually increase. So we're anticipating about 5% increase.
And I'd state collectively, the issue that we need to address is we left $8.5 million on the table collectively. We need a lot more engagement from both sides of the house. SJ Health did a lot within calendar 2023 than after to basically add people to the numerator or exclude people from the denominator. We did a lot of effort to get to 96%, but collectively, we left $8.5 million on the table, and that's what we got to avoid.
And Supervisor Kanika, really, the good news is, here's the good news. The QIP is estimated to increase by 50% this year, by 50% this year, not 3 or 5, 50. So is the EG, but here's the challenge.
So there is a positive in all this?
Well, no, there's only a short-term positive, because what we're getting the money from is a federal match, right? We're basically sending in 40 million so they can give us 80, or however it is. But I'm not being political here, but I would, according to CAPH, the QIP money is highly challenged if we have a change in administration, because it's not an area where typically a Republican, they're going to challenge that match going down the road. So
I
that's
believe
the
Dr.
big
Julio
concern.
has some comments.
No, I just want to say that there are a lot of opportunities to maximize this going forward. We have developed dashboards that we've been using for years where we, in real time, trend how we're doing. We even developed a dashboard for the hospital so they can track how they're doing with their measures in real time.
I would add to that, there have been monthly meetings with the hospital and collaborative meetings. Countless numbers of specific emails. We are very transparent. We are very motivated to perform well on this. There has been no lack of effort, in particular because this has been something highlighted this entire year.
Yeah,
You've
because
heard it
all in all, it's we.
Yeah.
So we are the
Yeah.
county, regardless of what
There's been no
the
lack of
differences are,
effort
so that's.
to engage the
we
hospital
need to get together, so.
on performing on this
I'm
program.
glad to see that. I'm glad to see that the communication's better. Thank you.
So this shows our estimated performance. It also reflects the chosen split via the MOU that currently exists. The reality is, we all have good points here, right? These monies are meant to stabilize public health systems as a whole. We need our public hospital. Whenever we need it, we're glad we have it. However, the future of healthcare is not in the inpatient space. Supervisor Canepa, Supervisor Ding, You both are aware of this, and I know this because you visited my side of town recently and visited Riverside University Health System and the Wellness Village. Folks, this is what QIP is for. The primary care space and the holistic care of the individual. We have an opportunity on the other side of the 5 freeway from the French Camp General Hospital, 22 acres, to build a behavioral health substance abuse center that includes potentially a PACE program for our elderly population, program for all-inclusive care for the elderly is what it stands for. We have the ability to put an FQHC clinic there, or urgent care. We're going to focus on things like, for example, physical fitness, mental wellness, hunger, and place a WIC program on that campus. Healthcare is where the individual is, and the individual is not in a hospital bed. In fact, we're trying to keep them out of there. That's where these monies need to go.
I
And when
agree
we-
with all that except the fact of the county. The reason the MSA was designed was because there was concern about the hospital falling off the cliff. There's no question that healthcare has shifted to the outpatient side, and we should do everything we can to make sure that we keep people out of the inpatient business. But the reality from a hospital perspective is St. Joe's sits at 380. That's the number of beds they have, and they run an average daily census significantly over that. San Joaquin has, why we decided to go to 152 from 200 is another decision that just rattles me on a regular basis. But we haven't, in the 2 years I've been here, because the 11th was 2 years, we've had 3 days. We've had 3 days where we had more beds than patients. Dameron is circling because of the challenges that they have. They had a significant loss last year. They were given a $50 million loan for a hospital distress, which essentially doesn't have to be paid back, but then they got hacked, and that $50 million went to covering the hack. For the most part, they still haven't recovered. So it's easy to say that we want to perform on the outpatient, and it's right, no question about it. But let's look at Stockton the way that we need to look at it. What's that, Lathrop? What's the fastest growing community in the state, right? Is it Lathrop or is it, all right? You have Mountain House that didn't used to exist and is now as a whole community. You have significant growth in Tracy, and you have significant growth in places like Ripon, all part of our service areas. As you move east, the hospitals that are there are very challenged, the little rural hospitals in Oakdale and wherever else. So, yeah, we need to focus on keeping patients out of the hospital, but we can't sit here and think that we are anywhere near bedded appropriately for this community and the challenges going forward. You know, if Joe's gets their tower approved and done, I'm gonna hang up on you, Dr. Capre. If Joe's gets its tower approved and done, best case scenario, we're looking at 8 years, right? The county hospital, all. I'll call you right back. Just stay in the lobby, right? Don't hurt anybody. And I'm dead serious about that. You're right. We want to shift to the outpatient, but there's no question that the inpatient sides of our capacity are significantly above. And if we had approval today for another tower or Joe's bigger tower, because Joe's has some challenges on the some docs own the land that they need, right? So the price has gone significantly up. There's no way that it would be a literal catastrophe if the county hospital wasn't up and running. And so all of the things that we're talking about, at the end of the day are the same. We don't need to agree, and I would recommend that you guys, get an opinion from an unbiased source about equipment, but it's irrelevant. We do want to move forward, and I know it's hard, and I'll take responsibility for my passion, kind of, but there's opportunity. And the biggest piece of it is we didn't need to go out and duplicate the expenses that we've duplicated. I think that's the first start that could say that we can bring all systems better. We do have great opportunities over the next year because we have significant increases. Will that change? I think we should all be realistic about that possibility and about just a different perspective from the federal government when it comes to healthcare under a different administration. That's not being political, that's just being factual. So it could get more challenging for us as well, which is the need not only on the, on the revenue side, but certainly on the expense side. We had big dollar spending with our travelers, terrible scenario. We're paying nurses $300 an hour to come here that weren't connected, and we got rid of them. We've replaced them. We've done some nice things with the county to make sure that we keep them. We have a lot of positive things going on here. And my hat's off. I do want to give compliments where compliments are due. You guys did a great job on the outpatient metrics this year. You got together, you nailed it. That's good. We need to incorporate the inpatient side, so we do that as a team together on all metrics. We're looking forward to that. But I still think we need to look at the expense overall and say, anything that's duplicated, let's stop duplicating it.
And I'd say the bottom line is really, as a public safety net, we sink or swim together. The hospital, the clinics, healthcare services, the managed care plans, we need all align, because ultimately, when we're talking about public population health, we're moving away from being paid by the visit or the inpatient stay to basically outcomes. And that's where we all need to align, skinny down our cost, take advantage of the opportunities that are before us, but really a lot more integration and collaboration amongst all the four legs as mentioned.
So, thank you, Mr. Diederich and Mr. Castro, for your comments. From the committee members, are there any other questions regarding the QUIP presentation?
Well, no, I'm just, so what the whole picture, I mean, we're doing the EMS stuff now, and I mean, the amount of times that ambulances are waiting, at hospitals, and I mean, I think that's part of the bigger problem is, I don't know if we can get that changed if we do the Be Well campus, is to get an alternate location for an ambulance to drop a human being off. And I think that's the biggest burden that I think a lot of us battle. Would that someday be addressed? Can we do that? Or because I think what's happening is you're taking a lot of mentally ill folks to the hospital and they're holding up beds and time and docs and resource. And I think if we do this and do a better job of collaborating collectively, that you can alleviate some of the problem of people sitting and they can't drop their patient off at the hospital because there's not a bed, or So I think there's a bigger picture that we can improve.
So multiple things are happening. Ultimately, we need the Be Well campus to have definitive care and take those individuals to that appropriate care rather than be boarded in the ED. The offload delays are multifactorial. Will the ambulance take them off? Will the hospital accept them in a timely fashion? Can we get them back into the system? But what we are working on is a lot of people brought in by ambulance don't need that level of care. So we're having some engagement with the managed care plans to staff a nurse advice line, basically at the 911 center, such that for the low acuity calls, that we could work there and have them diverted and basically taken by another means of transport to an urgent care or appropriate setting. And there is studies where this has been implemented in other large municipal areas. This could decant about 15% of the 911 ALS ambulance calls, and therefore have more ALS ambulances in the system and also improve patient care and outcomes.
Just from a liability perspective, I've been doing this too long. And the mental health problem started when I was, a CEO 20, 30 years ago. And you're absolutely right. The more opportunity we have to house them, but, behavioral health will be full the day that it opens, right? Will be full the day that it opens. And from an EMS perspective, the challenge of doing any of those things are always going to be liability. And it's that person that came in saying, I'm feeling weak, we'll take them to the urgent care, and then actually they were in the middle of a stroke or having a heart attack. And from a liability perspective, it's going to make that piece very, very challenging. And it's not It's not that we're not focused on the right thing, it's just, you know, the right thing would probably be a better reimbursement system for taking care of the mentally ill and the drug addicted, as opposed to trying to fit them into a healthcare system where the crux of their problem is not the crux of what we do. And you're right, once they get into the hospital, we can't admit them, because once we admit them, we can't discharge them. So they're stuck in the emergency room, which is a horrible experience for everybody, especially somebody who's having a mental issue. I'm just not optimistic that that we as a country are all of a sudden gonna address that problem. So that's the challenge of some of the things that are such good ideas, but have the challenge of how do we protect ourselves from a liability perspective. It's close. There you go.
And I'll add that this will also help us with, to continue achieving 2 QIP measures.
So that just about concludes my presentation. To reiterate a point that Dr. Dulio made earlier, we did reach out to some public health systems, namely Ventura County and Santa Clara County. Santa Clara is a considerably larger public health system than we are. Ventura is about the same size. Both of those systems are sharing not only QIP, but other supplemental funds, like, here's some more acronyms, GPP, EPP. Those are significant dollars that are being shared with the hospitals and the FQHC, inpatient and primary care, because they know where to put the investments. I have a feeling that once we develop this Be Well campus, folks will be flying in to see that, just as we did with Riverside. Thank you, committee.
And I'll just add, I think at the end of the day, what Chris has articulated and what we've been trying to do over the last 10 months is grow our revenue such that we need less QIP. We do need QIP to break even, but at the end of the day, where these monies are invested, it's above my Rick's pay grade. It's really a decision by the Board of Supervisors. Where do they want this investment within the county healthcare space?
Well, and inclusive of the FQHC board, of course, but I think we all know that.
Board members will be discussing that with you in the future. That's on our agenda. Okay, so I think this concludes this presentation, and we'll move on to the next agenda item, which is public comment. I do not see anybody in the room. Ms. Rivas, do we have any public comment?
There's no public comment.
Thank you. That allows us to move on to committee comments. I know that CEO Castro has a few comments, and then we'll go around the room if anybody has any comments. Mr. Castro.
So I apologize that we don't have a financial for this month. I thought we were supposed to. So I had, my CFO left us in July 5th. The very good news is the new guy starts August 12th. Very experienced, we're very comfortable with what he's gonna do. We've had a challenging year, especially over the last 3 months with the orientation costs exceeding about $2 million a month over our revenue, over our previous orientation costs. And that's the equivalent of, we hired 308 nurses. The good news is we hired 308. We started losing them, so we thank the county. We made a very bold move with increasing our nurse pays at the 0 to 5 years, or we're about to. Let me rephrase it. So we've shored that up to try to prevent them from leaving us. I'm very happy to the report, and I was surprised at this. The year-end projection shows the hospital exceeding budget by $2 million, so we're very excited about that. Part of that is the realignment that was, for some reason, budgeted at $7 million, but has come in consistently at 20, so it wasn't budgeted appropriately. It came back to our bottom line. So it's 2 years in a row for us that and we'll show this at year end when it's appropriate. But we're excited to say that we've done this now for 2 years. We're also very excited to say that, the whole goal of being financially stable is to allow us to focus on the quality and the patient satisfaction and patient access and all the things we're gonna do. I told you guys when we came here that we're going to take our Leapfrog F and make it an A. We're very, very close. I believe in 2024 we will be a B, and that's after 7 years of a Leapfrog F. And more importantly, the harder mantra to achieve is a CMS 5-star. We've been a 1-star forever. We are now a 3-star.
So in 2 years, we've made significant quality improvements. We've made significant financial improvements. And again, we're committed to doing this all better, this collaboration for population health. You guys need to determine how those dollars are allocated, and I think if we're one system and if we weren't separate, then all of these conflicts would have gone away a long time ago. And I, want to stress that we all need to focus on opportunities wherever we see them, whether they be cost or revenue. Thank you.
Thank you, Mr. Castro. Mr. Diedrich, I think you emailed me that you also have some committee comments today.
Thank you, Brandy. At one of our prior meetings, there was a discussion or a request to look at the referral pattern for SJ Health. So we did a little bit of analytics. I have an oral update, but for calendar year 2023, there was a total of 22,494 patients from SJ Health that were referred to specialty or ancillary services. 71% of those went to resources outside of San Joaquin General Hospital. We ended up looking at what went internal and external. The highest referral source was to SJ Health Internal Medicine, but when I look at the other end of the top 20, there's a lot that goes to SJ Health for surgery and orthopedics, but the bulk of the top 20 really are services that SJ Health doesn't offer. There's probably about 8 entities in the top 20 that are for physical therapy, ophthalmology, derm, tertiary care, including UCSF Medical Center. I did note that one of them was a gastroenterologist, and the hospital does have GI services. Talking with Dr. Dooley and some of our team, one of our measures for QIP is colorectal cancer screening, and the way we really significantly elevated that score was to basically run analytics on the patients, call them up, and if we could get a hold of them, say, hey, we can mail you Cologuard, which you see advertised on TV. You take it at home, you mail it to the lab, and if it's a positive, then you need a colonoscopy. And because access to colonoscopy at San Joaquin General Hospital is delayed, those are referred to community providers. So looking at this, the vast majority of what we can refer to San Joaquin General Hospital is, if they can accommodate it in a timely fashion and getting through some of the hurdles that we're collectively working out to streamline that access, that when there is access, we can get in on a preferential basis and that there is no unnecessary reasons to push that back. So I just wanted to report that 71% do go outside, but those are vastly because those services, physical therapy is all over this list, are services that the hospital doesn't in general offer. And I know Dr. Dooley might have some other comments in that regard.
Yeah, absolutely. To also include, we have spearheaded meetings with the hospital specialty clinics with Lindsay, who's the manager there, with Dr. Sadat. We've kind of got rid of the barriers that some of these specialty doctors were having, like you had to have an EKG within the last 3 months, or we won't see them even though they're an established cardiology patient. So we've erased a lot of those barriers where it's easier for patients to get in. We've also increased communication between the primary doctors and the specialty doctors, whether it be Tiger Tech, cell phones, so that we can also continue that communication, make it easier for patients to come in.
All of those things that we just talked about are opportunities. So physical therapy, we only offer inpatient physical therapy. Might make sense for us to look at the opportunity to, but we have to take a look, right? If we're getting 9 cents on the dollar, maybe it makes sense to refer that out. And that's the discussions that aren't happening in a very realistic way to make change. And I'll give you the GI example. The GI example, there's capacity, right? And when that information finally gets to us, we take a look at the statistics, we take a look at the number of procedures that our GI docs are doing, and we're saying, where's the disconnect here, right? You're telling people you're 6 months out and you're doing 4 procedures a day, right? No, you're not going to do that. And that's why that back and forth is really critical, in that we address that issue right there. So what Nirvana would be was the minute that we have a scenario where you're not getting cooperation because we're a single entity, we run it up the ladder and we fix it, like we
have with some of these specialists who said, you know, the challenge with the challenge with the employment model is there is no incentive. There is, you know, we don't have productivity in our physician contracts, something that I think we should all push for down the road. But the challenge is, there's no incentive on our employed physician side to do more, right? And in fact, you know, one of the biggest challenges that we had coming from what happened here prior to this administration was that we were, you know, just kind of letting our doctors do whatever the hell they wanted to do, you know. We'll work 12-hour shifts, but we'll really work 4 and be available. They fixed that. That's what we needed to do. But that culture is still having lasting effects that we need to get over. So there's tons of opportunity. Everything you say there is, we should look at everything we talked about and said, what should we do strategically? What should we do? Would it make sense for us to put a physical therapy unit in? Would it make sense for us to add another GI doc? Would it make sense too, right? And the conflicts that we have with call, for example, you know, clinic docs don't take it, hospital docs do. That's our fault, right? That's Rick and Greg's fault, right? We should have a system where it says this is what we need from our physicians, whether it be on the outpatient side or whether it be on the inpatient side, so we have a bigger pool to choose from. Same thing from an employee side.
And back to Mr. Dietrich's comments, going back since this is a review and not the woulda, coulda, shoulda is what we should do down the road. The actual mission of the clinics, other than the GS example you mentioned, we're on par. I mean, they are referring to the hospital what can be handled. So we're not leaving any money on the table there. I mean, for what is being offered from the hospital, other than the GS, we can expand, but they are sticking to their mission.
They are our preferred outlet. It's an integrated system. It's a shared electronic health record. As much volume that we could drive there and as much preferential access that they could provide to us as a safety net. It helps our patients. It helps our QIP metrics. And again, we sink and swim as an integrated system. Leadership, I think, are meeting regularly. We might have our differences, but at the end of the day, we're focusing on patient care. And I know he has Dr. Capre captive in the lobby. We're actually going to be conscripting this room for the next hour to work on some operational issues, but we're meeting on a recurring basis, leadership to leadership, but more so staff to staff. And that's really where the rubber meets the road, and we make some improvements. And hopefully the past is beyond us. All we have is opportunities, my opinion.
And I'll add that is correct. The priority is for our patients to be seen in specialty care at SJGH for numerous reasons. We have the dialogue with the physicians there. We share an EHR, electronic health records, so all the notes are shared with us. We get to see in real time. That's good for patient care because we know exactly what the specialist did. It's also good for QIP because QIP is doing certain things isn't enough. You have to code it appropriately and have the reports to spec to show that these things were done. So this is one less barrier. It is a priority. Like I said, we've been spearheading meetings with the manager of specialty care, with internal medicine chair, and to really knock down any barriers that may prevent patients from going to specialty care at SJGH.
Thank you. Are there any other committee comments?
Yeah, just real quick.
Supervisor
I
Campbell?
would like to have that QUIP person come and do a little
Yes.
presentation. That would be awesome. I think the thing is, the most important part is everyone putting their differences aside and fixing this. The more alarming thing that came out of this is that there were 3 recommendations, then they picked a 4th. So that's kind of catching me by surprise.
So point of clarity, so everyone has the same understanding. Eide Bailey produced one set of financials, supported by fact, history.
Right.
Results.
No, I'm saying of the MOU at the beginning.
The hospital produced 3 alternative scenarios
Okay.
that we were told are our options to choose from, 2 of which had the FQ paying the hospital millions of dollars for it to exist.
Okay.
That,
No, those recommendations came from a consultant, those recommendations.
Okay, so I
did
mean, that's the
not
thing
come
that we
from
need
the
to go
hospital.
fix going
So
forward,
I
and
have
we're going to.
shared
So I mean,
I have shared the email with our county administrative team, and they came from David Culberson.
But
and Chris
well, hold on for a
Roberts.
second. I think you're creating things to argue about.
Okay.
You said in your comments that you agree that there were 3 recommendations and the administration, whatever, went with the 4th.
Because the columns themselves said option 1, 2, 3, and 4 from the Hospital
But you
produced
guys are
spreadsheet.
you guys were under agreement at the beginning of the meeting, you didn't understand why they didn't pick from the three.
What I'm commenting on was a mistranslation.
Okay, so that's what I mean, going forward, because if this thing is
I
coming
just
up,
don't want anybody to leave with the understanding.
So
I hear you, not trying to.
Supervisor Canepa,
by 2025, so that MOU will
yes.
be
and
looked
we-
at and
Yes,
going
the
forward.
MOU and the co-applicant will both be
collectively.
looked at collectively
all right.
with both, well, all parties. The
And
MOU
doctors and
encompasses
whoever
many.
else is involved.
Everybody
and-
that
okay.
needs to participate,
Okay.
we will ensure participates. I mean, as you know, Mr. Castro mentioned it, leadership is completely turned over on both sides of the house. We have new excited board members. We have a lot of synergy to influence population health. And
Right.
that's what we have to go home with. That's what I go home with every day, is how do we make sure that San Joaquin County's population is healthy and taken care of?
Okay,
And
moving
we will
forward
keep everybody
collaboratively
focused
together.
on that.
Okay, perfect.
And to firmly put the fire out, I think at the end of the day, the reason the option was taken was that was the only option that did not necessitate opening up a closed and audited set of books for a prior
Correct, that's
fiscal
what I
year.
mentioned during my presentation.
Okay,
So,
all right.
are there any other committee questions or
Nope, I'm good.
comments? Supervisor Ding?
No, we're just looking forward to experiencing this grand, system in the north part of the county at some point in time.
Understood. I just want to make sure none of our other committee members have any comments. Okay, then we will adjourn. Thank you very much. We are adjourning at 10:06, and as a reminder, our next meeting, because we've moved to quarterly, is October 16th of 2024. Thank you, everybody.